Now we are recording. So if we want to go ahead and start, Mary, do you want to start us off?
Sure. So I was sharing with Connie is with us. Allison's going to introduce her from People's Action. But the other day I was sharing with Connie and Allison that I've been really struggling with what we call how we get healthcare, because you know, we keep talking about that it's a healthcare system, but it's really not a system. We could use a system. It's a healthcare industry, and we really I think as we go along tonight, we will hear and talk a little bit more about that and why our healthcare is so wrecked. And I think a lot of us know the impacts of not having a healthcare system. You know, a lot of us complain and experience poor healthcare delivery. We all know people who've gotten sick from very minor things and it's ballooned into other things because they haven't been able to get the healthcare that they need. We all know people who make choices between, you know, buying their medicine and purchasing some other necessity. And so we wanted to take a look at why that is. And People's Action, now you guys know Communities United for Action is part of a national network called People's Action. And while CUFA is not working on healthcare as an issue right now, People's Action is, and they have a healthcare campaign. And so we wanted Connie to update us on what's going on with People's Action and why, the whys and wherefores People's Action got into working on healthcare. And in some ways, I think it'll sound very familiar with all the other issues we work on because the underlying root causes all tend to be the same, but we'll get into that later. So I'm going to turn it over to Allison for some, what do we call them? Norms.
Norms, yeah. So as we've been doing these popular education series sessions, we've learned a few things along the way. So one of the things that I think that we have learned is what we've learned since we've been doing Zoom meetings, that it's really important, if you are not speaking, to mute yourself. So if everybody will take the opportunity right now just to figure out how you do that. So if you are on the Zoom that you join through a computer or through your tablet or your smartphone, you should have a little microphone, and you can if you are on a phone and you're joining us by phone, like Lenore, you're joining us, your audio is by phone. So *6 is what you will use to mute and unmute yourself. And one thing that we found as we were doing these sessions as well is we do want them to be really engaging. We do want you to ask questions and make comments and engage in the dialogue. And we've built in a lot of time to do that today. So please engage when there's points to engage. But when you're done, just go back on to mute, just so we don't get feedback or weird noises that make it choppy when the next person speaks. So there's that. Does everybody want to give me a thumbs up if you know how to mute? You got it down? You agree to do that? Good, okay. So the other thing, like I was saying, is we've got plenty of time for discussion here. We've built it in about like every block of the way with the stuff that we're going to be talking about today. And Connie does have a lot of content for us, so I want to make sure that she's going to be able to get through that content. So what we're asking for people to do is hold your questions until we actually open it up. And there'll be plenty of opportunities to do that. And once you've asked the question, give everybody else a chance to ask a question before you ask a second question. Does everybody agree to that?
Mm-hmm.
Yeah? Yep, okay, I see a lot of head nods. Okay, well, so I think that's it. Mary, am I leaving anything out of the norm? No, okay. All right, so without further ado, I will introduce Connie Huynh from People's Action. She is the Healthcare for All campaign director. And Connie, thank you so much for being with us today.
My pleasure. Hi, everyone.
Hello.
Hello. Good to see you all today. As Allison and Mary said, my name is Connie Huynh. People's Action is a national network of community-based organizations just like CUFA. I think we have 42 organizations that are part of our network all across the country. So we are connected and we make up a very big network. And we have three main campaigns. People and Planet First, which you all may be familiar with, which just released the Thrive Agenda, the Homes Guarantee campaign, and then Healthcare for All, which is the campaign that I lead. And we have a team, it's myself and Aija Niemer Honorud, who used to lead our student action work, that's part of our team. And we have 24 organizations that are part of the Healthcare for All cohort. So 24 organizations across the network, throwing down to ensure that we can expand healthcare to everybody. So I know that I'm here because of, kind of terrible circumstances. We're in the middle of a deadly global pandemic. And so healthcare is a really relevant thing that, if we weren't, really worried about it before, we surely are now, because so many people will be affected by the state of our healthcare system. But I'm really excited to be here and to be able to talk about healthcare because I think it's really important. It's something that I'm really personally connected to. And so I'm happy to be here in conversation with you all. Just to share a little bit about myself before we get started, I want you all to know that before I came to People's Action about a little over a year and a half ago, I spent 9 years organizing in the labor movement, did a lot of healthcare organizing, and this was right after or just before the ACA passed. And so I did a lot of work to implement the ACA, expand Medicaid here in Los Angeles County, worked with frontline workers, and, really did a lot to enroll people who didn't have healthcare before into coverage. It was a lot of work, and was really excited by it. And, I ended up leaving SEIU at that point, looking for my next challenge. And during that time, one of the most traumatic experiences in my life happened. My mom ended up having a heart attack. She was in the hospital for 10 days. I never left her side. Against hospital rules, I stayed there every moment that I could, to make sure that she was okay, and really was one of the most traumatic experiences of my life. Just at any moment feeling like we could lose her. The recovery was, probably even worse than the surgery and all of that itself. So it was then that I had realized really, sort of what led to that point. And it was that my parents didn't have access to healthcare until they qualified for Medicare. So 65 years. I grew up without healthcare myself. And so all of the ways of surviving without having access to like a healthcare system, I lived it and it was normal for me. And it wasn't until that moment in my life that I really understood sort of like what happens when you ignore all of these things or just try to survive through them, and what happens when, the healthcare system actually ignores people's pain. And so that really motivated me to fight for a stronger healthcare system, even after all of the work I had done on the ACA. And so as I do this work, I am, you know, I do it for my family. I do it for my parents who waited 65 years. I do it for my brother who waited until he was in his 30s. I do it for my extended family who are in similar situations, growing up without access to healthcare. I do it for my stepson, Tlaloc, who even with his parents having good jobs, my partner is a union organizer and has, you know, a Cadillac health plan. Our stepson cannot actually access a doctor in network unless he travels 3 hours to state line, you know, even with health insurance. So there are so many problems with our healthcare industry, as Mary rightly noted. And so we'll talk about some of those things, how we got here today, but also what we're fighting for in service of, you know, the vision for how we get out of here. So with that being said, I just wanted to create some space for you all to also name, you know, anybody that you are here for right now. So whether it's yourself, your family member, somebody that you know, I want to just invite you to name them, and if you'd like to share a little bit about their story.
Well, I would say the homeless people of Hamilton County who often don't have health care, often do not know that there's health care for them, for the homeless. I don't know anybody specifically, but I know of people
Yep.
that are homeless.
Thank you, Jerry. Ray, are you speaking? I think you're on mute if you are.
Yeah, I work in a hospital, and so I'm here for my patients, and I also had done my master's degree work in theology on healthcare, and so I'm very interested in this topic.
Thank you. Yeah. Andrea, I think I saw you speaking also, but you're on mute.
For me and my family and neighbors.
Thank you, Irene.
Irene, yeah.
Thank you. And Andrea, I think we just unmuted you. I think you were trying to say something a couple times.
Yeah, people that have lost their jobs and they don't have any access to health care.
Yes. Lots of people have lost their jobs recently and have also lost their health care in a time that they needed the most. So yes. Anybody else?
I worked in mental health for the people who had in mental health. A lot of them didn't have health care, and a lot of people that are not working who don't have health care. I've had some friends who are not working right now, and they do not have health care.
Thank you, Deborah. So many, you know, the first years of my organizing and work on healthcare included organizing workers who worked in healthcare facilities but didn't have access to healthcare themselves or their families. Okay. Thank you, everyone. So we'll continue to hold space for those that you just brought in here. Again, as we think about our healthcare system, it's not, you know, it impacts us and it impacts, you know, the world around us. And in this pandemic, we see that our health is tied to the health of everybody else's. And so, you know, if it wasn't a matter of justice before, we know that like we absolutely have to ensure that everybody has access to healthcare, not just, you know, for our own well-being in addition to theirs. So I'm going to share my screen. I have a little bit of a visual to share with you all today to sort of guide our conversation. let's hope that this works. And so the first part of our conversation, I just want to sort of give you an overview. I apologize if this looks a little detailed, but wanted to just give you all a sense of what we're going to do. We do have quite a bit of time, you know, here together tonight. So we just talked about who we're here for. I'm doing the overview right now. And the first part that we're going to dive into is people's action, values, and vision, right? And so what is it exactly that we are fighting for, and, you know, who is people's action? Because I think that that helps ground us so that we understand why we fight for the things that we do. And then how did we get here? So just a little bit on the history of the healthcare industry, and then what's the material change that we need? So, you know, right now through People's Action, we have two core issues that we're fighting for. And so I'll talk in depth about those. And then we'll have a little bit of a check-in, sort of like some reflection between the Medicare for All section and the section on the pharmaceutical industry. And I am condensing a lot of information into a simplified version for us tonight. So I'm not going to cover everything in the presentation portion, but we will have a Q&A in case there are some specifics that you all, you know, want to ask about. And then we're going to do, we're going to break out into groups so that we can have some smaller discussions, you know, smaller group discussions amongst us, and then we'll report back and share out with one another. And then we'll close out. I have, you know, some ways that you all can get connected and participate if you feel inspired to do that. And then at the very end, we're going to do an evaluation. Sound good to everybody?
Yes.
Okay, great. Okay. So the first thing I wanted to do is, this is not healthcare specific, but I wanted to share with you all People's Action long-term agenda. People's Action, just in case folks are not familiar, is a result of a merger of 5 networks actually in 2018. And so those 5 networks came together and became People's Action. So now we have, as I said, 42 organizations. And in the process of uniting together, we wanted to come together and define who we are and what is the, you know, what is the vision for which we are fighting, right? What is the new world that we want to build, and how are we going to win it, right? And so you see on the very left here, who we are. People's Action builds the power of poor and working people in rural and urban areas to win change through issue campaigns and elections. And then I circled in yellow here, people's new economy and society. That is what we are actually fighting for. So public control of the economy, right? So rather than corporations controlling the economy, people actually controlling the economy. Real democracy, so democratic control of our government and community control. And structural equity, because we know that even if we are to restructure our economy, that there's not true justice until we win structural equity. And that also means racial justice, gender justice, and other forms of justice. And global sustainability, because we've got to take care of our planet as well as our people. And so one of the key things that I also want to highlight in terms of how we're evolving our organizing practices, I don't know if you can see my pointer. Can you guys see my little mouse or cursor? Okay, great. So race, gender, and class as strategic forces. So not only naming the harm being done based on race, gender, and class, but also having an analysis that shows how race, gender, and class are used as a way to divide us, right? As a strategy for protecting wealth, right? So I think that those things really make People's Action unique, and also really informs why in a Trump presidency, right, under Trump presidency, we would be calling for something like Medicare for all, because this is the vision that we're actually fighting for. This is the future that we want. All right. So as it relates to healthcare, right? So the first, so there are three principles here, right? Three values that we're fighting for. And the first one is that healthcare is a human right, right? Especially in the wealthiest nation in the world, everyone should be able to access what we need to have the best chance at a healthy life, to survive, and to thrive. We believe that, and that is our value, and that is what we are fighting for, right? We know that as individuals, many of us will pay whatever we can to save the lives of our loved ones, but that ain't right, right? So because the costs are too high, and it's good for corporations, but it's bad for people. And so the government, our vision and our value is that the government should make it so that we don't have to pay whatever corporations demand of us, that the priority should be that we take care of our people, right? And so we are fighting for a shift, right? Where people come before profits, where it's people who we value and not commodities, not things, and not money. And lastly, all means all, right? I'm in the process of planning a series of discussions like this with some activists around the country. And, you know, we are intentionally shifting the way that we are organizing so that we are following Black leadership when it comes to discussion about healthcare. For those who are not, like, you know, if you're not involved with healthcare organizing, then you may not know that it is really predominantly white in terms of like who is leading the movement. And so we are making an intentional shift to ensure that, because we know that communities of color are disproportionately impacted by our healthcare system, and we need to have people of color leading so that they are actually shaping the solutions that we are fighting for. Can you give me a few minutes? Thank you. Sorry, I have a 6-year-old, so. Okay, and so, I was telling that story because one of the folks that's planning this with us is actually very involved in a movement here in Los Angeles, and he's a Black organizer, and he said, you know, when folks say anything for all, we know that for all doesn't necessarily mean Black folks, right? That for all means white folks. And even in that sense, we're not even talking about all white folks, right? Because we know that class, gender, all of these things are used to separate and divide us. And so what we are truly calling for is an all that really means all, regardless of, you know, marginalized identities, regardless of where you live, how much money you make, what your gender identity is, and what your citizenship status is. Okay. All right. So that is our values and vision and what we are fighting for. And again, why we are fighting for Medicare for all and not something else in the age of a Trump presidency. And I'll get into a little bit more detail about that. So first, how did we get here, right? So this is a very simplified version of like the history of the industrialization of healthcare and medicine, right? Because this healthcare system or healthcare industry that we're in is a relatively new thing. It didn't exist prior to the early 1900s, right? There used to be healers, lay practitioners, people that understood how our bodies and our health worked, you know, who helped people. And by and large, this is how poor people access healthcare, right? And under this, but it wasn't perfect, right? And so I tried to like sort of systematize how we were looking at this. So under pre-industrialized medicine, the providers of healthcare were healers and lay practitioners, and decision makers were healers and of course slave owners, right? And the objective of healthcare at that point was prevention and pain management. So we move into, so this is a system where we relied on our ways of knowing and healing. As a mother, I think of this often, right? In terms of, can we say hi? I think of this often because, you know, so much of childbirth is industrialized now in terms of like the type of healthcare that you need and the tests and all of that. But there was a point in time where mothers' bodies knew what to do, right? And there were definitely practitioners that supported them, like midwives and those kind, and you know, important people like that. But we've gotten to a point where even mothers feel like they cannot give birth without, you know, a medical system, right? And so just sort of like illustrating the evolution of how we take care of ourselves. So in the 20th century, we start to see the industrialization of medicine, where this thing called, you know, known as formally trained doctors starts to come up. It becomes this elite thing to know medicine and to be a doctor. You have to have this training, and, you know, obviously only certain people could access the training. And it had to be that way so that medicine could be elite and a scarce thing so that it could be commodified, right? So rather than a way of surviving and being about our health, it became a commodity. And the decision makers under this system were these doctors who had to be trained. It couldn't be you or me who knew things through experience, but it had to be a doctor that at that point actually was practicing really dangerous stuff that was no better for people's health than what people were already doing. And so the point was to legitimize this idea of modern medicine for profit and to delegitimize healing practices that were being practiced, you know, by people. And then, so that evolves. I'm skipping over a lot of history. But during that time, you know, we see like numerous attempts to outlaw abortions. We see, you know, this idea of modernizing maternal health. We see awful and dangerous things like the Tuskegee experiment that happens, where we are literally just watching people die, you know, at the expense of, you know, research, you know, some really awful things happening. And the awful becomes even worse. And so in the 1980s until now, we are seeing the medical industrial complex come together, right? So we have highly trained doctors. We see ancillary staff that are even like, you know, have to go through rigorous training. And we see corporate consolidation, right? Where for-profit health becomes a legitimate thing. Insurance companies who become decision makers and intermediaries between doctors and patients become a thing. And again, the objective is to make healthcare a commodity and reap super profits. So that is the system that we are currently existing in. So while it is not a healthcare system, it is definitely an industry, and it is definitely designed to systematically make lots and lots of money for people that are not us. And so in order to address this, we actually know that we have to reverse this trend. We have to tackle the industrial complex, right? We have to see healthcare as healing and survival, and we have to value our best practices in terms of addressing that. And we need, obviously, to have a healthcare system so that we can address you know, really specialized things and have access to that specialized knowledge and treatments when we need them. Like if you get in a car accident, we definitely need somebody who you know, can perform surgery on you, right? And to know what's going on. But so we don't want to dismantle the healthcare industry. I just want to be very clear about that. What we're fighting for is to ensure that that everybody has access to it, okay? And so the material change that we need are these two things that People's Action is fighting for: a Medicare for all system and a public pharmaceutical system. We want universal access to quality, therapeutic, culturally competent healthcare, right? We don't want just any healthcare. We need healthcare that is actually quality. We need a single payer system so that there is leverage, right? And to bring down the cost of healthcare. And we need wealth redistribution, because under the current way, so many people and families are devoting so much of their income to healthcare, right? Where healthcare costs rival that of like your living costs for the roof over your head, for the food that you eat, right? And it shouldn't be that way. And so imagine if we're able to redistribute the money that people are paying for their healthcare so that they can actually put that towards their housing, towards other things, what kind of a world we would actually live in, what more we could actually do in our lives, what kind of thriving we would do. And then the other is a public pharmaceutical system, right? So I'm going to go through this in a little bit of detail, but right now I'm just going to say we want to dismantle the monopolies that pharmaceutical corporations have. The reason why they're able to get away with so much is because they're the only option. We have to go to them for the medicine that we need. And so if they want to charge us $10,000 or $3,000 for a $10 medicine, they can do it, right? And that is happening right now. We want people-centered production of medicines. I'll get into that. And we want public negotiating power. So where we have to rely on corporations, we want the government to be able to negotiate for the prices, right? So if you're on Medicaid, Medicaid has the ability to negotiate with drug corporations. Medicare does not. It's written into law, yeah, that it's illegal for Medicare to negotiate with pharmaceutical corporations. And there's no other reason other than protecting corporate wealth. Okay. Just want to make sure I'm not skipping over anything, and I think I am, but I do want to share a story of a mother who is from Washington. She's actually no longer with us, but her mother is a leader within the People's Action Network. Gina Owens is the mother of Tiffany Owens, who passed away in 2007. And Tiffany had hypertension. And Tiffany was diagnosed with hypertension in 2006. By 2007, it had gotten so unbearable and so bad that she wasn't able to make her shifts at work. So all of that caught up with her, and she ended up, being laid off from her job. And so she not only lost her income, she was a single mother of 3. She also lost her health insurance at the time. And Tiffany felt like, she had worked, she was a working mom. She had paid her taxes. And she felt like it was the government's responsibility to put those taxes back to her so that she could access the medicine that she needed to manage her health condition. So basic things like pain medication because of all of the pain she was experiencing, diuretics, which basically flushed fluid away from her organs, she couldn't access. And if she were to buy those things, they were, you know, over $300 a month. And again, she had been laid off from her job. And she felt like if she were to buy those things, that she would be taking away money from what her children needed. And so as a mother, Tiffany always put her children first and refused to take away from her children for herself. Sadly, Tiffany didn't last very long under those circumstances. Things got to be very painful and unbearable, and you know, she passed away in 2007. And so now her 3 children are living without her mother, because again, we don't have a system that addresses people's fundamental needs. These were not, you know, one, hypertension is a preventable, you know, like people don't have to die from hypertension. This is something that like we can prevent deaths for, yet we are not. And again, the medications that she were on were not rare. They just were not available to her because for economic reasons. So, you know, had we had a Medicare for all system, Tiffany wouldn't have had to deal with those things. She would have gotten the medication that she needed, and her children would likely have their mother still with them today. Okay. So just to drill down a little bit on Medicare for all, I like to think of this in like very simple things. So one is what we're calling for is to improve Medicare, right? And then expand it. When we say improve Medicare, it's because some people who have Medicare right now are saying, there are so many problems with Medicare, why do I want other people to have it, right? And we recognize that right now, Medicare is not a perfect system. Like I said, by law, Medicare cannot even negotiate, you know, medicine prices. And so there are a lot of reasons why there are flaws within Medicare. And it's because we've come to this point of patchworking our healthcare system, and the industries have really done a lot of work lobbying to make sure that Medicare has the least power that it possibly can. But even with all the flaws, Medicare is the largest, you know, health insurance program that is administered by the federal government. It actually does have a lot of favorability. So even if, like, you know, there are flaws with it or issues with it, people can actually access the healthcare that they need, right? So like I said, my parents now have access to the healthcare that they need. If they didn't have Medicare, we would have really been in a bad situation had my mom had a heart attack without Medicare. And so we want to improve Medicare, meaning we want to include more services. So under Medicare for all, we would actually have all primary care, hospital and outpatient services, dental, vision, audiology, hearing, right? Women's reproductive health services, maternity and newborn care, long-term services, prescription drugs, mental health services, substance abuse treatment, laboratory, diagnostic services, ambulatory services, and more, right? So all of the things that we need to actually get the healthcare that we need would be covered under a Medicare for all system. And we would not have financial barriers, because that is one of the biggest reasons why people are not able to access their healthcare, right? Is because we can't afford it. So whether we can't afford premiums, we can't afford co-pays, we can't afford deductibles, we're, you know, in enormous medical debt. Those are the reasons why we can't do it. And so we need to eliminate all of those barriers so people can actually use the healthcare system. And then we need to expand it, right? So once we've improved it, we want to make sure everyone in the United States is covered, regardless of who you work for, where you live, how much money you make, race, class, gender, age, etc. You would be covered under a Medicare for all system. You would choose your provider. There would be no networks. So my stepson would not have to drive 3 hours to state line. And again, long-term services and supports for people with disabilities and older Americans. And then we would be able to guarantee healthcare in all communities. So under a Medicare for All system, you can actually guarantee payment in rural areas so that you can actually keep doctors and hospitals open there. Whereas right now, because it's not profitable for people to, practice in rural areas, we're seeing a lot of closures. And so people in rural places either cannot access the healthcare they need or maybe have to drive 3-4 hours just to get to a doctor, right? So that is really dangerous. So yeah, that is what we are actually calling for. And under COVID-19, we see what's actually happening, right? So the number of jobless and uninsured are increasing. Somebody mentioned earlier, right, like all of the people that are losing their jobs right now. We are definitely seeing that under COVID. Before COVID, there were 70 million people in the United States that either didn't have health insurance or couldn't afford it even if they had it. So like, I had health insurance, but it's such a bad plan that I can't even see my doctor because it costs me too much, right? And now under COVID, we're likely to see over 100 million people because of all the people that are losing their jobs and thus losing their health insurance. And of course, the number of employed and insured are going down. And so healthcare is becoming scarcer when people need it the most. Again, this is on trend with what the healthcare industry wants, right? Is that it becomes even scarcer. Then people are willing to pay even more for it, right? And you all know this. And this entire system is being upheld by racism for profit, right? And so what we are all experiencing together, Black and brown communities are experiencing, disproportionately worse, right? And we've seen this actually in history. During the HIV and AIDS crisis, right? It was a crisis that was known for impacting gay men, but also Black people. And the epidemic disproportionately impacted Black people from the very beginning. And that disparity has just grown over time, right? To the point where Black Americans make up 12% of the US population, but account for 43% of current HIV and AIDS infections, right? And so if we think about that system from then, and we look at what we're experiencing right now under COVID, we can see that it's sort of a foreshadowing of where this is headed, right? We're already seeing the disproportionate rate of infections in Black communities and communities of color. And so there is a lot at stake here. And so with COVID-19 under Medicare for All, I don't want to say it's gonna like be a miracle of some sort or, that like will wipe out the pandemic, but it sure as hell would make things a lot easier in terms of how we address the situation. Having one centralized healthcare system, right? Rather than a patchwork of insurance and Medicaid and Medicare. We have to pass all of these bills to make sure everybody is paying for COVID treatments and all of those things, right? So while we might be impacted by COVID and we might see jobs decline, more people will be insured under a Medicare for All system, right? And community spread, if we all have access to healthcare, would actually go down, which means the pandemic would be more contained. Which means if the pandemic is more contained, then maybe we could actually safely reopen our economy, which means jobs and the economy would go back up, right? And if we are able to, access jobs and reopen the economy, then people could afford to pay for their housing and education and other needs. So all of these things are a cycle. And as you all know, all of these things impact our health as well. And so, and again, you know, our individual health depends on the health of others. And so really we see the importance of being able to take care of everybody, especially in a situation like this. This is an extreme situation, but we are here and we've been in it for months and we're not sure when we're going to get out of it. Right? So I've just said a lot. This, you know, is sort of like the illustration of our healthcare system, what we are fighting for. So I just wanted to check in with you all to see how you're seeing this show up in your communities. I know that we talked about, you know, people losing their jobs and all of that, but how are you seeing the impact of our broken healthcare industry in your community?
So, and everybody just note, you'll have to unmute yourself because I think about everybody is muted. And don't be shy.
Okay.
Cost of medicine. I do able to pay for my medicine because we have a fund because I'm a state employee, but a lot of people don't. And I just went and got some medicine last week and it cost me $121. That was one prescription.
Mm.
Yeah. And as you said, you actually have that coverage, right, Deborah?
I've got coverage, but how many people that don't have that? What do you do if you don't have that coverage and you don't have someone that's going to help you pay for that? What do? You get your medicine, or you don't eat, or you don't pay your rent, or what do you do?
Yes, exactly.
So in my neighborhood, at my local Kroger, there is the nicest guy who works in the cosmetic section, you know, with the soap and shampoo and stuff, who is retired. I think he's about 76. And he worked at AK Steel for like 30 years and retired, but is stocking the shelves at Kroger because he needs to get the healthcare coverage. And I know that's really common in our community where we're seeing seniors take second jobs just for the healthcare. It'd be nice if our seniors could just retire when they're ready.
And imagine the health impact. Yeah.
Connie, I have a question. I know that the medical industrial complex thrives and makes a lot of profits because they're more interested in the fact that we're sick rather than we're well.
Right.
And I'm just wondering how this factors into your plan here about good nutrition, good exercises, keeping our bodies healthy so that we don't need quite so much medicine.
Right, right. So like I said, in terms of reversing the trend, we've got to, one, dismantle the power that corporations have to define sort of what healthcare is and what we actually need, right? Because it's corporations that are telling us, you need this medicine, you need this many doctor's visits, you need this treatment and this test and those kinds of things, right? And once we remove the financial incentive for them to be able to do that, then we'll start to value again, right? Wellness, nutrition, conventional ways of healing and those kinds of things. But we can't even begin to do that and have people where people actually value that because again, corporate notion of like medicine and health is what shapes, you know, how we address our own health.
Yeah.
So again, so many women don't believe that we can, you know, give birth without the assistance of a doctor, right? Just that as an example.
Yeah. But you know, I think food is sometimes the best medicine, and we know that instinctively, but doctors aren't even trained in nutrition, for example. They're just beginning to tell us, give us therapies that don't include medicine, but then we have to pay for that.
Right. And then there's access to healthy food and those kinds of things.
Right.
Thank you for that question, Jean.
Connie,
Yes.
this is Lenore.
Hi, Lenore.
I'm quite elderly. I'm pushing 80. And as a very young child, I was the benefit of a different type of medicine. Back then, your general practitioner, your family doctor, had to be an expert in a whole lot of things. Our family doctor was a surgeon. He brought to birth every child born in the hospital in our county throughout World War II. And surgeons have to take a lot more training than an ordinary GP. There was an epidemic of so-called yellow jaundice. He called every patient that he had with children and got us inoculated with gamma globulin. He was not a specialist. He was simply a highly well-informed, highly educated, and highly dedicated general practitioner. And I think since now, I mean, you're brought into medical school saying, oh, you have to specialize. That's where the money is. I think there has to be some kind of internal reform of the entire medical system or doctor system, where the top dog, again, is the general practitioner, the highly educated, highly skillful guy with a general outlook. And I think he needs to become the top dog in our whole medical system again. Not all these specialists, not all these pill prescribers.
You know, when students go through the medical exams at the end, they have to get jobs, and the one that's paid the least is a general practitioner. They're paid less. They're not valued as much as a specialist. So everybody comes.
Yeah, I was going to say that.
Well, they aren't as good as they used to be either.
Yeah.
Yeah. And it's got a whole heck of a lot to do with our public education system as well. Because, you know, if you're coming out of medical school with $100,000 plus in debt, what do you want to do?
Yeah. And all of this is rooted and driven by this idea that healthcare and medicine should be a commodity, right? And so that is how we have gotten here, where, you know, general practitioners have become, if you can even say this is not the correct terminology, but like de-skilled, right? If we're saying, oh, they're not as good as they used to be, because all of the specialized sort of care has been sort of separated out, and that's where the money is, right? And so less people are interested in becoming general practitioners, more interested in the more lucrative fields. Again, it's a, you know, a commodity. And so this shapes how we value and how we think of our own healthcare and the treatment that we receive. And on top of all of this, you know, we've got like gender bias, all this implicit bias like woven into the system, racism, right? Whether or not on an interpersonal level, people are actually paying attention, acknowledging and listening to their patients, right? And so there's a lot to unpack here. So I think that these are all really good comments and reflections on the healthcare system. And I agree that there's a lot to restructure. The thing about Medicare for All is it's sort of like the most sweeping thing you can kind of do, right? To reform our healthcare system as a way to begin the reversing the trend and creating an actual healthcare system where it's not a commodity, but a thing that exists for the good of the people, right?
I also think that they use the computer all the time now. They very seldom touch you. They very seldom listen to your heart, listen for your lungs. They're asking you what's going on in your body, and they're the doctors. And a lot of them still pushing a lot of pills. They get a lot of perks from these pharmaceutical companies.
Mm-hmm.
So they give out samples just enough to get you to go to the pharmacy to buy your medicine. And a lot of the doctors are in, what do you call them, conglomerates, where they're with either TriHealth or Mercy Health. Those are the two in our areas in Cincinnati, Ohio, and just about all the doctors are there. So when they charge you, they get so much, and then the company or the merger they're with, they get so much.
Mm-hmm.
So it's a lot.
Yeah.
Yeah.
They also get money from the insurance companies if they sell you their drugs.
Yes, you're right. They sure do.
Right.
But that's if you don't, wait a minute. That's if you have Medicare and insurance, your insurance is second. So really the Medicare is paying for it. And then afterwards, the insurance is paying.
Right.
And then
you
pick up.
Right.
And then you pick
correct.
up.
That's right.
Yeah.
Mm-hmm.
My question is though, where does the pharmacies fit into this, such as Kroger, CVS? How do they all fit in?
That is a really good question. I won't get into the level of detail around like individual pharmacies, but there's a whole other like distribution side of things that is actually not part of our campaign around pharmaceuticals. Our campaign addresses sort of like the root causes for why people are not able to get the medicine that they need and that we serve, right? Do you have a specific question about the pharmacies that I can try to answer?
Well, I'm on it's called Care, CBS Care Marker, meaning that my medicine comes by mail. And they tell me that it's cheaper that way than to go to Kroger's and get my medicine. And I'm just wondering, you know, and I know it depends on what type of medicine you have, whether or not it's high or cheap. And Kroger's has this little program that they run, and I don't really belong to that program. And you know, well, I was just wondering how that was. Anybody that belongs to it.
Can I make a suggestion? What you have to do is search around to the different pharmacies. Like Sam has a very good medical program also, where you can get your medicines cheaper than you would if you got it from Kroger's. Also too, I would just compare the prices, because sometimes some medicines are cheaper when you get it from your insurance companies or when they send it to you than it is if you go to Kroger's or Sam's and vice versa. But so far I found Sam to be the cheapest. They have a program.
Yeah, all right.
Yeah, and so I wonder if it's actually a system like, instead of Medicare negotiating those prices, it's all these different entities trying to entice you into their program that is on a smaller scale trying to negotiate prices, and then you get a better deal based on who happens to have negotiated a good deal for this drug, but it might not be that drug.
Right.
But
there's current ads on TV that have different systems, and it's probably what some of you all were talking about. In other words, somebody will go to their smartphone and go like this and get it much cheaper, the prescription. But if I can, since I got there, a couple of observations is that you talked about what the general practitioner is doing. Well, the assistant does all the work and puts it on the computer for her, and then for he or she, and then the doctor comes in and evaluates it. And if I may, I just went and got my 6 months evaluation, and because I had to put my hand at the ear because we had masks on, I'm going to see what do you call it, an audiologist? So my thought with this discussion is they do referrals to their specialist.
They're friends. They're friends.
Yes, all of these things happen, and this is what we're talking about, right? I mean, our system has evolved from, you know, again, healing people, pain management, to like I'm going to detect every single possible thing, you know, because it's all connected to profits, right? And
Connie?
Yes.
This is Lenore.
Yes, Lenore.
And it addresses profit directly.
Right.
I was told years ago, probably 10 years ago, that health insurance and professional baseball are the only two entities in the United States that are not subject to antitrust laws. Is that still true? Because if it is, that is part of the root of the problem of drug prices.
That is a very good question. I don't know if it's just baseball and pharmaceuticals, but something tells me that.
Oh, it was.
Okay. So then that tells me that you're probably correct, Lenore.
So most of the profit in the healthcare industry is going to drug companies. So how do we combat that? What do we do as people?
Yeah, so I want to, that's an excellent question, and segue into our next piece. And I just want to pick up on, you know, a couple of things that were brought up. So first of all, Irene talked about, you know, different programs and how to access the medication. Big takeaway there is like the medicine pharmaceutical industry is designed to be complicated. You almost need to have a PhD or some doctorate degree to like know where to buy your medicine, right? At a place, you know, at a price that is reasonable to you. So I was going to ask, you know, the question to you all in terms of what difficulties you're actually experiencing, accessing, you know, when trying to access medicine. But I think we've been hearing it so far. And so we know that one, medicines are not affordable, right? Even with a benefit, Deborah is paying over $100 a month just for one prescription. Two, as a result, some people are having to ration their medication, which is very dangerous, right? And then three, there are shortages. There are not enough medicines in supply. And under COVID, it's getting worse. And we're still seeing, you know, pharmaceutical corporations trying to maximize their profit, even under COVID, especially under COVID, because now is the time where they can do it, where, you know, people are going to be so desperate for their health. And as an example, I don't know if folks are familiar or have heard of remdesivir. It's a drug that's made by Gilead Sciences. That's the corporation. I just want to say it so that we can name, you know, the actors behind this. But it basically, it shortens, you know, your time to recover from COVID. It's not even really a treatment for COVID. It just shortens the time that it takes to recover from it. And that frees up hospital beds. So people can leave the hospital earlier, then other people can come in. So you keep the healthcare system going. But even with that medication costs $10, right? And remdesivir, Yes, and remdesivir, or Gilead Sciences, is saying that they will charge $3,000 for it, right? And so, and then when we talk about a COVID vaccine, that is not a thing that is guaranteed for all. If you are paying attention to what the administration is saying, they're sort of dancing around the subject, saying, maybe, you know, it'll be available. You can't guarantee it's going to be available to everybody, right? And so, again, this idea of like how we actually get out of the pandemic without people, you know, having access to the basic things that we need, so that we can all, you know, be safe. And so here is how we got here. So this addresses, this is sort of complicated, but I will walk through it. Somebody just asked the question about what we can do as people, and this is the current system that we are under, right? So what we're seeing is people here and profit here, or pharma here, the pharmaceutical industry. And what we are seeing is people keep paying money out, right? We are actually funding the research for all new, you know, most new drugs. Like any drug that has come to market in the last 16 years, any new drugs in the last 16 years, were all funded and developed through taxpayer money. So we actually paid for the development of these new drugs. And then we are paying money because the government, after we fund the development of these drugs, is handing over the patents and the licenses, the exclusive licenses for these drugs, to private pharmaceutical companies. So then they get a monopoly on the drug. Remdesivir was researched through taxpayer money, right? Now Gilead Sciences has a patent on it. They're looking to expand the patent. They tried to expand it 7 more years at the beginning of the pandemic. So again, money going to pharma. And then we go to the counter, or we wait for the medicine to come in the mail, right? And we are paying in the price of our medicine, again, to pharma. So the money keeps coming out from us in all of these different ways. And pharma continues to collect all of the profits. So there's really 3 paths. And then pharma takes that money that they made from us, and they are investing it back into lobbying so they can secure their monopolies, so they can make even more money. The more they control, the more power they have to set the prices. The more they can say there's only this many drugs, and so you have to pay even more money for it, right? And this, folks, is the pioneering industry of neoliberalism. The pharmaceutical industry is sort of paved the way for taking government money and privatizing it and making, and just, you know, gaming the system for their profits. So that is why medicines are so expensive. So what we're calling for as a solution, right, is that the people can pay for the research for the new drugs, but we need to actually produce it. So we want to have public manufacturing, right, so that the government can redistribute it to the people without having to go through pharma. So instead of monopolies, we want to be able to produce it. Then that allows for generics and, you know, all of that, so that there's more medicine in supply. And again, you know, there's not the price gouging that we're currently seeing. The price gouging is because there are monopolies, because there's a controlled supply. And then on the other end, you know, we want for Medicare to be able to negotiate. So under a Medicare for all system, we want Medicare to be able to negotiate with any pharmaceutical corporations that are in existence that have, you know, their own patents and medicines that they've developed on their own, right? So under Medicare for all, what sort of the difference is that we're calling for, you know, what do you call it? Dismantling the healthcare or the health insurance industry, to where you don't have an intermediary that's making decisions about, you know, what kind of healthcare you can get and how much you're going to pay for it, right? That's a direct relationship between you and your doctor, and you're not involved in any of the costs. It's the government and, you know, and the doctors or the providers that have that relationship. You just go in, you get the treatment and the services, and that's all you need to know. In terms of public pharmaceutical system, we don't necessarily want to dismantle the pharmaceutical industry, but we definitely need to like restructure power around it so they can still exist, but we want to be able to control a lot of what's in circulation.
Connie, can you just clarify what you mean by the people produce the pharmaceuticals? What does that look like?
So our federal government actually has 6 manufacturing facilities where we can produce medicines, and none of them are being used because, you know, private corporations have these exclusive licenses. So we don't even have the rights to produce the medicines that we have created through our research. Yeah, mind-blowing, right? It's awful. It's awful. But guess what?
Instead of handing over them the patents.
Yeah, instead of handing over them the patents, we just created ourselves, right? What's even more mind-blowing is that right now, the federal government has the ability to just do away with these patents, to say, with the stroke of a pen, you don't need Congress to do this. With the stroke of a pen, can exercise its power to say, we're going to start manufacturing this drug, or we're going to start giving licenses out to manufacture generics so that more companies can make this medicine, but we're not doing it. And so that is the other campaign that we are running through People's Action, is we are just going straight to the federal government. It could be any agency, it can be the president, it's executive action, and just demanding, exercise the power that you have. Make sure that there's enough medicine in supply. Make sure that everybody has access to at least COVID treatments and vaccines. And so, I mean, in terms of like, again, our healthcare system, pharmaceuticals, we need to center the people, right? So dismantle pharma monopolies. We want the government to produce the medicines that we're researching and developing. And we want to be able to have, you know, public negotiating power so that we can actually leverage our power against corporations.
Is this partly, Connie, is this partly what happened, I'm thinking here in the state of Ohio, when, and it happened in other states.
Eileen, you just blanked out on us. We can't hear you anymore. Okay.
Okay.
Oh, there you are.
Well, yeah, my other thing just went down. But this is what Governor DeWine got universities to do the testing, or to analyze results of testing, bypassing some laboratories, et cetera, that were more expensive or couldn't turn things around fast enough. So could it be done on a state level? Could something be done about pharmaceuticals on a state level?
It can, though it's not sustainable. I think that there are cases where states can exercise their power, but again, you know, their jurisdiction is just for their state. And so the other states don't have access to the same thing unless there's some sort of like agreement. And, you know, the quickest way, and I mean, the most sensible way, is to do it at the federal level, especially when the federal government has the power, has the resources. Like, there is absolutely no reason other than, again, maintaining this system of, like, you know, price gouging and monopolizing medicines.
Yeah.
Yeah. There are a lot of things that we could do at a state level, but also, again, in this moment, you know, state and local budgets, I'm sure you all are aware, are strapped for cash, right? And so a lot of states are going to make, you know, cuts and are talking about austerity and all of those things. And so, you know, really the federal government has the resources to do these things. And so that's why we want to just go to the federal government and demand the thing that they need to do.
Yeah.
Yeah. So just as a summary, right? So we are fighting for a Medicare for all system. This is the path to victory here is legislative action. So we do need Congress for this. And so we are continuing to, you know, wage our campaign. Medicare for all is our North Star vision. I think that we have made the policy case in terms of why Medicare for all makes sense. We have made the case to the people, right? As you can see from polls, you know, of voters, the vast majority of people support a single payer or a Medicare for all system. It's Congress that we are waiting on. And so our elections are critical, and our advocacy following that is also critical. But with our pharmaceutical, you know, with our pharmaceuticals and with medicine, again, we can go straight to the federal government and demand the thing that they need to do. And there's nothing more that, you know, not much more other than like signing something. So that is where we are putting our resources and our effort. And yeah, that is what we are fighting for. So any questions?
Oh.
Connie, I have a question. Why do you think it is, I mean, because like I just heard this whole big thing around executive actions that have happened to lower drug costs currently. And, you know, I think that people are really pretty confused. I'm confused about what it actually did and what was the negotiation. So I wonder what the heck just happened. And then two, you know, what are the barriers to executive action on giving up that, on actually moving toward production and not giving out all of the patents?
Can you repeat that one again?
Well, so like recently I heard there was an executive action that lowered drug costs. I don't really know what that executive action is. It was like, it looked like it was maybe some sort of negotiation, and then like, I don't know if it was even a meaningful action, really. And then what do you see as the barriers to that executive action happening to make, you know, our government stop giving away our patents and actually start doing production?
Yeah, so that's a really good question. And I actually, full disclosure, am not caught up on the executive action. One, because we know that Trump is just doing things, right, that sort of give the illusion of actual action, but they're not. And so he has committed to lowering drug prices since his campaigning days, and none of that, right? And so this action is just, again, another sort of like facade in terms of creating the illusion of like negotiation, but not actually delivering it for people. And so I can actually get back to you on that, but I don't have like a full analysis for you.
I have a question. The Obamacare, the Affordable Health Care Act, that is something that Biden wants to improve on and continue with. Does that do what we want it to do?
That is a great question. Well, I think that, one, we can see that under the ACA, what happened was that we expanded the private health insurance system, right? And as long as corporations are in control, as long as health insurance is sort of like the intermediary, then we are not going to actually be able to access the healthcare that we actually need. And so expanding that system actually strengthens corporations' ability to fight against a true healthcare system. The thing that Mary is calling for, right? A system that actually works. We would be working against that by giving insurance companies more power. So Biden, you know, what's being proposed is a public option. And what that means is that you would make Medicare available for people to buy it, right, in the marketplace. So along with private insurance, you could choose to buy Medicare. Now, again, this does not mean that we would improve Medicare. So you would be buying into the current Medicare system. And not everybody can buy Medicare, right? And then once you do, again, like all of the problems with the existing system come with it. So it's not a true solution. And again, it actually, from our analysis as People's Action, it actually hurts us because it enables corporations to game the system so much that if we do offer a public option, corporations will game the system. Medicare will, you know, fail in their eyes. It won't meet the standard that people need because they, you know, we're buying into a bad system that has like no leverage and no power. And we make the case for them that Medicare is not capable of running our healthcare system. And so it's actually a really dangerous path and hurts our ability. People think of it as a stepping stone, as a way to get to Medicare for all one day, but it actually hurts our chances of being able to do that.
I have a question about Medicare for all. Will Medicare for all mean that everybody pays the same amount for their insurance? Or how would that work? I mean, for everyone, so everybody can get it, because some people don't have jobs.
Right. That is a great question. And the thing that, right now, what people pay for their insurance is called an insurance premium. Under Medicare for all, there would be no insurance, right? And so there would be no insurance premium. And so people are not paying that premium. So what happens is you actually go to, you know, you go to the doctor and the doctor provides a treatment and the doctor bills care for it. So you're not even involved in all of the, what do you call it, you know, paperwork and billing and all of that. And there's no insurance.
So who would the doctors bill? Would they bill the insurance companies? Would they, who would they bill? The government?
They bill Medicare.
Okay, so they would be billing the government.
Yes.
Gotcha.
But the government will likely have some sort of fee arrangement, right, that covers all of the services that they need. So they're just paying a flat rate to make sure that everything is covered.
But there have to be a mandate for everybody to be enrolled for this to work.
Everybody will automatically be enrolled. You don't have to do anything to actually enroll.
Okay.
Because everybody's covered. So there's no reason to like qualify or any of those things because nobody's excluded.
What about the cost? I mean, I've got Medicare and it's not cheap.
Right.
That's right.
Sure isn't.
Right. Under the existing Medicare system, it's not cheap. And what is being proposed under Medicare for all is, again, there's no premium. So you're not actually paying for Medicare. Because what the idea is, over the next decade, we would actually reduce the amount of money that the federal government is paying for our healthcare system by trillions of dollars. And so Medicare would actually pay for itself. So we could cover everybody, provide more services, and it would cost us less, cost the government less to do so. But you have to make sure everybody is in it or else it doesn't work. And you have to make sure there's not a private insurance system or else it doesn't work.
What about hospitalization? How would cover hospitalization? How would cover medicines? ambulances? I mean, would this Medicare for All cover everything?
Yeah. So that list that I went down earlier includes those things.
And long-term care?
Yes, long-term care as well.
Okay, long-term care also, okay.
Mhm.
I would make an
And when is this
observation
supposed
that
to take place?
I'm sorry?
I just
And
want to
when
make
is
an
this
observation that this has been done in so many other industrialized countries. It's not like we're inventing something new. It's that America has been kept in ignorance of the possibility of Medicare for all. I think if we just studied other countries and how they did it, we might have these questions answered.
Yes, we have not only been commodified, we've been colonized.
Yes.
Accept this. We've been colonized.
Yeah.
Other countries aren't.
Connie,
Yes.
on those payments, would you be able to shed any light there? Is it like the ads on the TV say, I don't have, when you start out paying for Medicare, you're on Social Security and you give $135 a month for your Medicare. That's just backup information. Now they're saying I don't have to pay the $135, and they're going to include eye test and dentist and everything else. Are you familiar with any of that?
I'm not familiar with
Yeah.
that.
Yep.
Okay. In other words, it's the whole idea to me is, because I'm not on it, who's paying for it? And they're telling me I don't have to pay anything if I described it correctly. In other words, I don't have to pay the $135 a month, and then I don't have to pay any copays. And the conclusion is, to me, if it's too good to be true, it's too good to be true.
Are
Anyway,
you talking about Medicare for All or a current program?
No, with the current situation, the ads on TV are you don't have to pay the $135, and then you sign up with us, and you don't have to no co-pays or anything like that.
Yeah, I don't know about that one. Your instinct or your gut may be right, but I couldn't actually say for certain.
Excuse me, Russ. I'm sorry, but I was gonna say, to answer that, I just talked to somebody about that, and you don't pay for anything, but in the long run, you end up paying for something, because when you go to the hospital, you have a larger deductible.
Yeah, probably.
And you have to qualify. You can't just, they don't tell you that part. You have to qualify also.
Right.
There's some way that they're going to get you.
Mm-hmm.
That's their whole, reason for existence.
Connie,
Yes,
what would you say is the #1 major obstacle to this vision coming about of Medicare for all?
I would say it's the political obstacle. The corporations have made, we know that we don't have clean elections, right? And so there are lots of lobbyists that have lobbied our members of Congress. And so it has been difficult. I mean, even with so much popular support for Medicare for all, again, voters are saying, 60, 70% of voters say they want a Medicare for all system. And our electeds are coming out and saying, people love their health insurance. They don't want a Medicare for all system, right? And these are industry talking points. And the industry now is even fighting the idea of a public option and just saying, oh, we should just build on the ACA, right? And so it's really all of the money in our elections, right? And all of the money that's in our lawmaking, basically, that is really an obstacle. And so, that is certainly a challenge for us.
Thanks.
Yeah, absolutely right. Good question. Okay. Such great.
Connie,
Yes.
this is Lenore. I'm seeing a lot of commercials lately. Obviously, they're produced by drug companies or lobbyists for drug companies, but they say how our entire medical treatment and expertise in this country is going to just go down the tubes if we have Medicare for all, and that it's socialist medicine and everything. I'm not seeing any commercials that bring out the facts that there are 14 other countries in this world that have a lower infant mortality rate, a lower maternal mortality rate, and about 7 or 8 other universal health factors in which countries that have so-called socialist medicine rate higher than we do. I mean, they talk about how wonderful our healthcare system is. Well, we do some incredible research in this country, but it stops there. The care system is broken.
Yeah, it absolutely is. And of course, they're not going to bring up the facts because then they wouldn't be able to make their case, right?
So, what action can we take to make this happen?
Well, I do actually want to get to that, but we're actually supposed to do breakouts first. I think we are maybe stretching it on time. So Allison, Mary, just want to check in with you all to see, should we move into breakouts? If so, what should we do?
I don't see Mary. What do you think, Mary? So could you show us those questions, or do you, because I think we would get more of a discussion if we did it in breakout groups for those particular questions, but maybe we do it just for like 10 minutes. And I'm going to say we were thinking about just keeping the Facebook Live on for the action part at the end, but I think we could just end the Facebook Live. What do you think? Yeah, okay.
Lenore, do you want to report back for our group?
Yeah, I guess. I thought we were group 3, but
I don't know.
basically the first thing we discussed was the relationship of our sewer problems, our housing problems, and our utility and water problems to healthcare. And, we agreed that, that sewers are very definitely basic to good health. And, just recently they did tests on the sewage from a college dorm, and that's how they detected active COVID-19 in that dormitory. Housing, if you have housing that's mildewed or got sewage coming up in the commode or just simply has deteriorated to the fact that it's noxious, that relates to health care. And certainly if you don't have clean water and an abundant supply of it, and heat in the winter and air conditioning for your asthma in the summer, that is very definitely a health-related situation. Did I miss something, Mary?
I think you got it.
Okay.
Oh, except for the mosquitoes.
Oh, yes. Willie's mosquitoes in his front yard in summer, and his, Zika, Ebola, meningitis, and his ice in his front yard and his sidewalk in the winter.
That's before MSD fixed things. Now that they halfway fixed it, I don't have that problem.
Well, that's good. And what was our other question?
How would the issues we work on be improved if we had Medicare for all?
Well, in the first place, people would opt for treatment earlier when a problem perhaps first reared its ugly head. Ergo, they get treatment before it gets worse and much more expensive to treat. And I'm really beginning to fumble here.
Well,
You
right,
covered it pretty well.
and the cost would go down, right?
Right.
And we also agreed that people could get COVID testing.
Yes. Which, as long as there's tests available.
Mm-hmm.
But you could go in and be tested more easily.
All right.
So we had Jean in our group.
Okay, I took some notes for us. I think we settled some of the same things that you did. If we had more resources, because we didn't have to pay so much for healthcare, we could do more with our housing and energy and then also the sewer problems. What we could do if we had more resources, we could maybe pay for some more research on what's making us sick, like in our sewage, whether it's pollutants, toxins. There's so few studies on this, and we're somewhat at the mercy of the corporations that do this research. We could maybe do it on our own and pay for it on our own. Let's see what else. Yeah. So, anything else that we talked about on that? So we would take a lot of, oh yes, we'd also take a lot of stress off us. That would in turn help our health prospects a lot more too. So yes, I think this would alleviate a lot of the burden of and free us up to pay for things that would even make our lives better and our health better. So then when we went on to the other question, we really got into a big discussion here. What could be improved if we went for Medicare for all? We would pay more attention to keeping healthy and with the right kind of food and water and therapies and exercise, and maybe even making community gardens, which would enhance our community life. And also thinking about, as Allison was saying, we could learn how to take care of each other. You know, caretaking is so undervalued in this for-profit system, and they don't pay caretakers very much, but then this would enhance this sense of community and taking care of each other and build community life. Then we started talking about, we just totally change our economy, that just redistribute wealth and better public services. Then we started talking about a little bit, well, is that a socialist system? And isn't there a stigma against that? What is socialism anyway? So that's where we went with that.
That is excellent.
Thanks, Jean.
And in our group, Ray is going to report back for us, but I just, want to say that we had some real-time organizing happening also in our breakout. So we had discussion and organizing happen. And so some good stuff came out of there. But Ray will report back on the actual discussion that we had.
So we had a pretty lively discussion talking about the sewer justice, about children getting sick, and whether there are clinics in the neighborhood. There was a question like, do we still have clinics in the neighborhood? And Jerry addressed that with a lot of his experience. He said the clinics exist since the Medicaid expansion. The reason for them to avoid emergency department visits, and you're really not supposed to be able to turn people away. And then the question was, where are these clinics? And so there was more information about that. And Debbie talked about how people have been dying sometimes from lack of meds. So it sounds like the information is not really easily accessed by everybody's not aware of these clinics and the availability. So that was the bulk of our conversation. It was a long time before we got to the second question. And again, we got more into the nitty gritties about knowing how to access healthcare interventions. We talked a little bit about children and having, I guess we were talking about lead paint and issues related to getting children to Children's Hospital. Sorry if this is sketchy, but I was listening more than I was writing. And we were talking, really, there's exchange of numbers and talking about how we can actually get, I think if I were to sum it all, I think what would be helpful if this vision of healthcare were to become a fact, there'll be a lot more simplicity and accessibility. I mean, Henry David Thoreau talked about simplicity, simplicity, simplicity. And I think we got complexity, and headaches. And I think that's where we would see the change being a helpful and effective and fruitful in our lives.
Yeah.
If there was more to add, I'm sorry, I forgot it. So that's what we talked about.
I second that. That was really good. Unless anybody else has anything to add.
Well, I would add, I think maybe CUFA could benefit from, some information about various clinics, because I just thought of some more clinics that I forgot about. But there's a lot of health, there's a lot more clinic locations, school clinics that have opened up. There's quite a few alternatives, or at least access points into the healthcare system.
I got his phone number, Allison.
Did, and I was going to say, email that information. We do have a COVID help page on our website, and we certainly can put that information up.
Mm-hmm. So
thank you.
Great.
I'm sorry, but I have to leave. But I've enjoyed everybody. Thank you so much.
Thank you for being with us, Andrea.
Thank you.
Yeah.
Thanks, Andrea.
Bye-bye.
So yeah, we're about 4 minutes over. So I think we'll probably have to cut the evaluation piece of it. But Connie, if you want to do your last couple,
just do it.
I know people did have questions about how to get involved and.
Yeah. So I will do this quickly. Thank you everyone for sticking with us. I know that it is late. I'm in California, so I have the benefit of it being a little bit earlier. But I think, thank you all for inviting me to be on here with you tonight. Tells me that I'm doing my job if people are asking, what can I do? So here are some things that you can do. I mean, we are a national network and we're fighting for this as a campaign, but here are a few simple things that you can sort of do to plug in. First, follow us on social media, because we are continuing to release actions that you can take. And because we are in a pandemic, a lot of these things happen online. So you'll get announcements about things that we are doing. So that is the best way to get plugged in about what's happening nationally. If you want to go straight to the source, you can go to our digital actions page on our People's Action website. I put the link here, and I'll send this to Mary and Allison so they can share it out with you all. But that will take you directly to our digital actions, and you can if you want, check regularly to see what's happening there. And then the third thing is we are part of a national campaign to pass Medicare for All resolutions locally. So I heard that there is something that passed recently declaring racism as a public health issue. This is also another way to sort of like put our local electeds on the record and to have conversations with them about our healthcare system. Somebody also asked a question about what can we do at the state level? This is a way of bringing this federal issue into our community. So there's a website that has tons of resources, even sample language. So if anybody is inspired and really wants to do this, The toolkit is on the website for you, and you can do that. And if you have any questions, you can feel free to reach out to me. And with that being said, you know, these are the ways that you can plug in. And if I could just click this, just want to let you all know that, you know, again, we have a Healthcare for All team at People's Action. So it's Aisha, as I mentioned earlier, myself, and then our campaigns department director, Sandra Udelman. And so we are available. If anybody, you know, wants to talk more about healthcare, please reach out. And I will, again, send my contact information so you all know how to reach me. And that is it.
Thank you.
Absolutely.
That's great. Thank you so much, Connie. And just so everybody knows, I will post the recording up on our website along with these slides, which you'll be able to click on those links if you didn't get a click on them in the chat, or obviously you can't click on them when Connie shares her screen, but.
All right.
Thank you.
Well, thank you again, Connie, and thank you to all of you for coming tonight and spending some time with us and having some really good discussions about this. So we are going to have a rescheduled Homes Guarantee session when John Washington is able to reschedule it. So we'll send you information out about that. It should be in a few weeks. So, all right. Well, thank you again. Thanks to everybody here. We'll give you a round of applause on Zoom.
You.
Not necessarily. A round of applause for you all. Thank you so much for having me tonight.
Connie, I just want to thank you so much for your clarity on all this. Thank you.
Oh, thank you, Lenore.
Yeah.
Really appreciate
Thank you.
Thank you.
Thank you.
Bye, everybody.
Very helpful.
Bye.
Okay.
Good night.
Bye.
Night. Bye.
Good night.